So hi, my name is Natasha. I'm a Senior Programme Manager for the Finance PMO at Leeds Teaching Hospitals, and we look after the Waste Reduction Programme. You, within your own trusts, probably call it Cost Improvement or SIPs or something along those lines, but when we say Waste Reduction Programme or our schemes, that's essentially what we're referring to. Any project that we're undertaking to save some money this year. I'm going to hand over to Jackie, first of all, and Jackie's going to take you through what our previous process was, outline kind of what we did with our quality impact assessments and what the challenges were that we were facing. Then I'm going to take you through the sort of practical element of it, the things that we did to try and solve some of those issues. And then I'm going to hand back over to Tom, who's going to take us through some of the outcomes and some of the feedback that we got from it. So I'm going to hand over to Jackie, first of all.
Thank you, Sasha. So my name is Jackie Armitage. I work as Programme Officer within the PMO team at Leeds Teaching Hospitals Trust. And Tasha, you all right to share the slides, yeah? Thank you. So I'm just going to talk you through. So I've just put a slide up there because year on year we were seeing an increase in the number of savings schemes within our waste reduction programme. And for an example, in 22-23 we had roughly 700 schemes. This is showing this year's 24-25, and as you can see, there's going on 1,200 schemes, and it's still, it still grows. So we're going to probably get more than that. We've got a good completion rate at the moment. We're at 85% completion rate, and that has got a lot to do with how we've changed the way that we work with our checklist. So you can imagine there's a lot of high volume QIAs to be checked, completed and proved with that number up there. So we had colleagues started to question, do we need QIAs for every single scheme? Do we really need a QIA for schemes that like under £1,000? Because there's a lot of work goes into these schemes, they're very time consuming when you've got to fill out all the paperwork. So we knew we needed to address this issue. So we used the Leeds improvement method to identify improvements with this checklist, so that we were able to modify the policy that we have, so that only those schemes that would have a potential impact on quality would necessitate a QIA. So how did we do this? So we formed a project group within the PMO team, the financial management team, and held some ideas workshops. The outcome of this was an easy checklist to follow with some excellent guidance, all in the same document, which was a lot easier. We've got some slides to show you the before and after checklist later on. So one of the steps in implementing the bit, especially around do we need a QA for schemes under £1,000, the limb that was used for that was a tool called the 6 hats. It's a lean tool, and Natasha's going to talk you through some of the lean tools that was used in this workshop. So I'll hand you over to Tasha. Thank you.
So as Jackie's alluded to, we have the Leeds improvement method at Leeds Teaching Hospitals, and it's definitely our go-to management method and our improvement method. And there's 3 real buckets in that for me. So the first thing is the philosophy side of it, and it's very rooted in respect for people. And when we talk about respect for people, we talk about those that do the work, improve the work. So Jackie is the officer who's in charge of implementing our quality improvement process, and us as a team that sort of monitor that. It's very much our daily work. So rather than being told how we needed to change this, the senior leaders at the organisation empowered us and said, those that do the work, improve the work, you've got the best ideas about what will and will not work. We empower you to go away, have a think about it, include the people that you need, and change your own work. So we had the tools of the Leeds improvement method as well. Jackie's already referenced one of the ones that we use, the 6 thinking hats. I'm also going to talk to you a little bit about 5S as well. So that's very much what we do, and the leadership side of it touches on the how we do that, because what you do is important, but how you do it as well can be just as important. Making sure that we did it collaboratively. You can see some of our Leeds Way values there. I've already said empowered, but that we're collaborative, that we're fair, that we're patient-centred. So making sure that we use the right leadership methods as well was a really big thing. So I'm going to talk you through a couple of the tools that we used first of all. And one of them, hands up, you can either put virtual hand up, or if you're on camera, give me a bit of a nod if you've ever had a problem that just niggles away and you think you've fixed it, and then it rears its ugly head again and again and again, or it just keeps coming back and you can never get rid of it. Yeah, we've already got one up, and I can see Elaine a bit of a smirk as well. We have millions of them across Leeds Teaching Hospitals. So when we have those persistent problems that we don't quite nip off, we'll try something and then it hasn't quite worked, we go to a LIM tool called thinking differently, or sometimes we call it creative thinking or innovation. It's got a few different terms. But it's the thing that we need to do, because quite often, and I think the Albert Einstein quote there sums it up, we can't solve your problem using the same thinking that's created the problem in the first place. The quality impact assessments were brought in 5 years ago when the PMO was first formed, and we've tinkered with it. But we needed to really think differently if we were going to solve this problem once and for all, and stop all these pockets of moaning and this, do I really need to do this quality impact assessment for everything? And the way that it was chipping away at the culture of people thinking that they'd become a bit of a tick box exercise. So we really wanted to look at how we could do some creative thinking to once and for all deal with the issue. And there's a couple of tools in the Leeds Improvement Method that we use to direct creative thinking, because it can be a bit, you can go off and do all sorts of stuff and maybe never come to something that you can actually implement as change. So the first thing that we did was talk about our mental valleys. And we talk about these a lot within the Leeds Improvement Method. And the way that I can explain them to you, or the easiest way I find to convey that, is the mental valleys are the things that, when you go on autopilot, and because you've done that way for so many years now, it's now ingrained in you, can stop you from thinking differently. So if you take crossing the road, for example, we look left, we look right in England, don't we? And then we cross the road. That keeps us really safe. It helps us be able to get to work or wherever we need to go without using too much brain power. However, if we were to move to America or somewhere else that drives on the other side of the road, looking left and looking right doesn't keep us safe anymore. It doesn't help us get to work. So it's been really mindful of those things where, because we've always done it that way, is it stopping us from thinking differently? So we had to really question what our mental values were that were stopping us from thinking differently. So we did a quick session where we got those people that Jackie had mentioned together, some of our PMO colleagues. We had an accountant, we had someone who works out operationally within our clinical service units that fill these impact assessments in. We went in, was like, what mental values have we got about QIAs? And some of the things that came up were, they don't really add any value, they don't do this, we have to do one for every single one of them. Any assumption that we made about our work, we put on that mental values list to make sure that we were really paying attention to them. And then we jumped into using the 6 Thinking Hats tool. There's a couple of different tools for escaping your mental values that we use, and I'm going to mention a couple of other ones that might be useful to you before we get into the 6 Thinking Hats. And the first one is 7 ways. So quite often when you think about solving your problem, if we ask you for 7 different ways that you might do that, you can give 1 or 2 off the top of your head. These are kind of similar to things that we've thought of before. But if you're asked for 6 or 7, that's usually where you are really going to start to think differently. And we combine that with, we put sort of a challenge in there. So if it's a problem with communication, you might say, right, think of 7 ways that you can fix this communication problem if everybody spoke a different language, or 7 ways you can fix this communication issue if nobody could speak at all. How would we communicate with each other on this ward? So it puts a bit of creative thinking in there, but it pushes you towards thinking of things that you've never thought before. So when you get into ideas sort of 6 or 7, it's usually somewhere that you've never mined for a solution before, and you might find a little golden nugget in there. The next one, that dressing up box, is about being somebody else. So sometimes we'll ask people to pretend that they're from a different organisation or somewhere else. At our recent conference, we did a section on cost improvement, and we were like, right, be somebody else, be a different organisation. How would Disney do cost improvement? How might Donald Trump do cost improvement? And it was quite a fun thing for them to interact with, and they wrote all sorts of stuff down. And then, not that we're expecting for them to go away and make cost improvement great again hats or anything like that. It was just a funny exercise for them to do, and then take away the learning and the sentiment that sits behind that around, advertising, cost improvement, all of those things, to really help them to think differently. But the one that we used was the 6 thinking hats. And to give you a bit of a break from listening to me drone on for the whole entire hour, I've got a short video for you to watch that explains the 6 thinking hats, where the concept came from and how to undertake it. So if you can give me, Tom or Jackie, can you give me a bit of a nod, make sure that it's playing?
In 1985, a Maltese physician called Edward de Bono published a book called 6 Thinking Hats. The book described a powerful technique for looking at decisions from a number of important perspectives. The premise of the method is that the human brain thinks in a number of distinct ways, which can be deliberately challenged. If you look at a problem with the 6 Thinking Hats technique, then you will solve it using all approaches. Your decisions will mix ambition, skill, sensitivity, creativity, and good contingency planning. So, how do you use the tool? You can use 6 thinking hats in meetings or on your own. Each thinking hat is a different style of thinking. Let's have a look at what they each mean. When wearing the white hat, you focus on data, study the information you have on the subject, and see what you can learn from it. When you switch to the red hat, you will look at problems using intuition and emotion, sometimes called gut feeling. Try to think how people will react to your decision emotionally. The black hat has you looking at all the bad points of the decision. This is important as it highlights the weak points in your plan. Switch to positive thinking when wearing the yellow hat. This will help you focus on the benefits of the decision and the value in it. This can be really useful when everything looks gloomy and difficult. The green hat is all about creativity. Let the creative juices flow and develop creative solutions to problems. Finally, the blue hat is about process control. When wearing this hat, you decide which hat is the most suitable for the stage of decision making. For example, if ideas are running dry, you may decide to switch to the green hat. By analysing your decision wearing the 6 different hats we've talked about, you can feel confident about your decision knowing you've considered all points of view.
So whistle stop tour of 6 thinking hats there. So I'm going to talk you through what our group found when we put each of those hats on, when we were thinking about some of the questions that had cropped up. So that Jackie mentioned earlier on, do we really have to do everything, a QIA for everything? If it's under £1,000, can we just not do one? Or are there certain situations where we just don't have to fill one in, please? Because we've got so much to do. So first of all, we put on our white hat. So the white hat is all about what data or what information might you need to be able to make a really informed decision. So we started to think about, well, how many QIAs are we doing? So in our current process back in 2023, we were doing one for all 700 schemes, no matter what. But what about schemes under £1,000? How many of those do we have? Is that a big chunk of the amount of QIAs that we're doing, or is it only a really small problem? And when we looked back through year on year, we are actually doing more and more schemes every year under £1,000. The bigger that our targets get for saving, and the more that we've done quite a lot of this work already, every little helps. So people were really saying, right, I've got this thing that'll save us 500 quid, I'll chuck it into the mix. So year on year, we are seeing more schemes that would fall into that under £1,000 bucket. So we realised it was probably a bigger problem to solve, and it was only going to get bigger. So definitely something that we should be looking into. When we put our blue hat on next, we started to think about, realistically, within this process, if we changed any of the rules, what would we need to update? So we would need to update the template for the quality impact assessment itself that everybody fills in. We'd need to update the guidance that went along with it and the standard work. We'd need to update our monthly reports, because Jackie creates a report that goes out that says how many have been done, how many are outstanding. If we were going to introduce this new not applicable, we'd need to update all of those reports. So we thought, practically, if we need to do this, what do we actually need to do? And the hats kind of start to build on each other, because it's a good, now that we know how many we're going to have to do, we can make an assessment about how much work is this going to take to do, and is it worth it for the amount of QIAs that we might potentially release people from doing. So they do start to build on each other, and you get a bit more into your thinking as you go through the hats. So we put on our sunshine yellow hat next, and that's all the positive stuff that can come out of this. So we talked a lot about being able to give staff their time back. So the process, as you'll see when Tom shows you before or afterwards, the original form was quite cumbersome to fill in, and it had a lot of open questions. So it was really, how long's a piece of string? People would ask us, how long is it going to take me to fill in? Depends how verbose you are. Some people write a little bit, some people write a lot. So quite a lot of staff were spending quite a lot of time filling these in. So we could give the staff that time back. And it would also start to contribute to that feeling that this is a tick box exercise. You know, we know that it's not going to affect patient safety or quality, but we've got to fill these in anyway. And that was eroding away at the ones where it was really important to do this. And we knew that eroding away at the culture of how important these quality impact assessments are was a really dangerous territory to be in. We wanted to do everything that we possibly could to try and counteract that, and make sure that every time somebody filled this in, they felt like it was really adding value and keeping our patients safe. So we also thought it would encourage some more schemes as well, because what we know is people, as I've said, that target is getting bigger and bigger. They are coming to us with smaller schemes to say, I've got this to throw into the mix. But quite often what we do know is, if it's a small amount, people might not want to bring that to the table. I don't want to do all this paperwork for the amount that I'm going to save, so I'm just going to keep that under my hat. So we thought it would encourage us to get more schemes as well. But then we thought about a black hat. We put that on, and I think this was where we spent the most amount of time, because technically this is supposed to keep our patients safe. We're supposed to be looking at it from a risk point of view. So thinking about all of the dangers and the threats and the risk that might come into play if we made this change and we said, you know, you don't have to do them for anything under 1,000 or in certain circumstances. We started to think about, you know, the CQC element of this. It's mandated that we have to undertake quality impact assessments, and we know that CQC have given us quite a good feedback on the ones that we have at the minute. So what would happen if we changed that? You know, we could make a change where we might save 10 quid. I think we had one in 2017 that actually gave us 17 pence, but that 17 pence could have actually cause someone a little bit of harm. So we could save a tenner but cause £1 million worth of harm, or God forbid hurt a patient. So we were starting to think, I don't know that we can say that the amount of money and the amount of risk are related. That was a real fear for us, and a bit of a risk there. There was also a risk to the process as well. If we're going to introduce a point where it's not applicable sometimes, how are we going to make sure that when it is applicable, we catch all of those each time? We're only human, and people are bound to interpret guidance wrong, or, you know, things slip through the cracks. So we knew that there was not just risk to changing our position, as in with patients, there was risk to our process as well. So we put a red hat on next, which was pretty easy to define after doing our sunshine yellow and our black hat around. So what are your gut feelings about this? And a lot of that was clouded by that black hat that we just put on, and we were saying our gut instinct really was that the amount of money that you save does not actually correlate to the amount of risk and the impact to patient safety and quality. It was a bit scary. There was a lot of, the more that I think about this, the more that I don't want to do it. I don't want to say yes to it. But from that sunshine yellow hat, there was still a gut feeling that we wanted to give staff some time back, and we thought that that was really valuable. and a real need to do something that, like they will protect that culture and move away from tick box exercise and back into every time we fill one of these in, it really adds value. And that helped us with our green hat ultimately, because we were thinking, well, what's the alternative then? If we're saying actually for everything, no matter how much it costs, you need to fill a quality impact assessment in, but we still want to release some time. What are the alternatives? So we started to throw up things like, well, what about if it's a change that's come about because of a NICE guidance change, or some other safety and quality committee within the trust has introduced a change and actually a financial benefit is just a happy coincidence? Are we really then going to make them fill in a quality impact assessment for all of these things when they know the answers already? That is contributing to that tick box mentality. So maybe we could say, actually, we can't give you the gift of anything under £1,000 you don't have to do, but we can give you the gift of you don't need to do it in these other circumstances. And we also push that a little bit further to think about the form itself. If we're talking about giving staff their time back, let's put the form on the table. Can we change that so that it's less cumbersome and is a lot easier for them to fill in? So some of our tips when we've done this a few times now with certain problems that we have are to start with your yellow hat. If you start at that black hat and you start with the dangerous, the threats, the risk, all of that stuff, you can't really move past it. It clouds every other hat. So I'd say start with your yellow hat so that you can keep in mind all of the great things. If we have the guts to go for this and pull it off, what are some of the benefits that we're going to have? So you can keep that in mind as you work through your other hats. And then finish on the green as well. So knowing what you know, now that they've all built on each other, I know what information I need, so I know how I need to change my process and I know what my risks are. If I'm leaning towards actually, no, we can't do this, finish on your green hat where you know everything else that might then be able to show you what some alternatives are. And the other thing would be to keep your mental valleys in mind, especially on your black hat, because when we were thinking about CQC and about other things, what we realised were a lot of the risks that we were thinking about were actually perceived risks around, well, we can't change the QIA because it needs to have this in it. When we actually looked back at policies and CQC guidance, we'd sort of made these rules up in our head over time. There was a lot more scope and a lot less risk when we checked in on those mental values of the black hat. So I'm just going to circle back to this. How can we change the QIA to make it a shorter thing to fill in and save people time, and go through one last tool that we used, and it's a tool called 5S. So I'm going to play you another really quick video to introduce the concept of 5S. So, oh, it's starting again. Stop. So I'm going to talk you through a little bit of how we 5S our form going forward. So that video was geared more towards using 5S in a physical space, which is what we do most often in the hospital, but it can be used on anything, digital space, on a form like we did. So I'm going to talk you through that a little bit first of all. So the first thing we did was we had our 5S team. We used the same team that were in the original workshop when we were thinking about when we did the 6 thinking hats. So that was essentially our 5S team. We pulled out the levels of achievement grid. And if you want to do your own 5S, there's plenty of 5S levels of achievement grids on the internet. You can just Google one, they'll pop up. And we fell at the first hurdle. We didn't even get past level 1 when we looked at that form. Because when we thought about sorting the necessary from the unnecessary, we looked through that whole form and went, is everything on here really, really necessary? There were quite a lot that instantly we just got rid of. We were asking people to fill in information that actually it was available elsewhere, or it wasn't essential to be on that form. So those were a few of the things that immediately we thought, right, let's remove those from it so that we're only keeping every field on that form is something that we absolutely need. And then the next thing was about simplifying. Again, on that video, it says make places for the necessary items. So if you're in a stock cupboard, put the things that you use most often right in front of you, or can you simplify that? Can you put everything in alphabetical order so that it's kind of simple to understand where things are? On that form, the simplifying came in simplifying the language. We realized there were a lot of acronyms and things that actually, if I was filling this in for the first time, I would look at that and go, oh, I have no idea what any of this means. This is really hard. So we simplified a lot of the language on there, and we simplified a lot of the how you fill things in. So we changed things to tick boxes or drop downs where we could, to kind of make it a bit easier to understand what it was that you needed to put in that box and to save a bit of time filling it in. Sweep, again, if you're in a physical space, it's about being able to look around that and see if anything is missing so that you can make sure you bring it back before you need it for the next time. So for this, it was more about how do we make sure that everybody filling that form in understands what they need to fill in, and if it's really obvious if something hasn't been filled in, to the person filling in the form, and then to Jackie when she's looking through them afterwards and making sure that everything is filled in right. So you'll see on our updated version, it's a bit more colourful. We've colour-coded some of those boxes so that they would turn certain colours based on the information in them, so it was really obvious if you hadn't put the right thing in. Standardise, it does say on there, create a standard agreement with everyone in your entire team. So if you're talking about a stock room on a ward, that's really easy, isn't it? We're going to restock on a Thursday. We're going to do this. So-and-so is going to do that's really easy. But we were talking about a form that could potentially be filled in by any one of our 22,000 staff. That's a really hard thing to make an agreement on. So we made some really clear guidance and we tried to change it. It's about how can we make this form so clear that whoever is filling that in, no matter what grade they are, what role they're in, what team they're in, whoever fills it in, we should get the same outcome each time. So a lot of our standardising was moving away from open questions, how might this work, or asking an open question that had narrative put in, so anyone, no matter who they are, would answer in a different way, to more closed questions around a yes or no indication to whether things would affect quality or whether it might affect timeliness of care. So moving away from open to closed questions really helped us standardise a lot of this and cut out a lot of the time that it was taking for people to fill in. And then the self-discipline side of it is true. It's the hardest bit to maintain, but a lot of that is going back to your 5S team and getting their ideas. This is encourage ideas when defects occur. I've never once tried to change a process or implement an improvement where it worked first time and there were never any defects and everything was grand from the get-go. And the same thing happened to us. The biggest one that jumps out was Jackie bringing straight back to the 5S team. Actually, I've had a few in and it looks like there's a glitch. The colours aren't right and there's a bit missing on the bottom. I think something's wrong with the form. Jackie, dealing with that defect straight away, helped us figure out where this glitch in the template had happened, where that was saved, so we could go in, remove that, put a new template in that worked perfectly before any of our operational colleagues then tried to use that form again. So keeping your 5S team and keeping a track of when you're having defects and fixing that, coming back together to fix them again, is really, really useful when it comes to sustaining the problem. Because if we hadn't have got in there and fixed sustaining the problem, sustaining the solution, so if we hadn't have got in there and fixed that problem straight away, people would have gone back to using the old form. People are always going to go back to what they know because it's the easiest thing to do. So we found that any defect that we get on those forms, if we bring them back to the team and make them part of our self-discipline, we can make sure that we're embedding the change. And I'm going to hand over to Tom now to show you sort of the before and afters and go through some of the benefits that we found and some of the feedback that we got.
Thanks, Tash. Hi, everybody. My name's Tom Burden. I'm Programme Manager at Leeds. So yeah, this is our before and after in terms of form. So not particularly cumbersome before, but after it's significantly less. So as Tash talked about, we went through some of those columns and just removed some of the things that we just didn't need. So we've got significant fewer fields. You'll see previously we asked the same 5 questions essentially in the new form as we did in the old one, but rather than just a yes or a no in the old form, we asked for an explanation, which instantly caused issues because what we were receiving incomplete forms, so people didn't fill in all the boxes. So we were having that constant rework, and when Jackie's receiving hundreds and hundreds of these, that rework can take a long time. So yeah, it's fair to say that standardizing it and almost making it easier. The visual controls as well massively help. So you can see, when people put a yes in the box, it turns green so that they know it's good to go. We've done things like on the scheme value, we've just put a little tick box, because what we were finding is somebody would fill in a QIA, they'd put a very specific value, so it was for £2,000, say, the scheme. By the time we were implementing and updating that scheme, it might be worth £10,000. It might be worth just £1,000, and almost our form before was wrong. Whereas actually, after, what we've got is we've just got a scheme value sort of box. So is it under £5,000? Is it between £5,000 and £50,000? Is it above £50,000? Those types of things. And we removed duplication. So again, scheme before, this form before might have had things like scheme lead. We've got that on our tracker, so we know who the scheme lead is for those. So we just don't need it. And we talked about moving from 700 schemes a few years ago up to nearly 1,200 schemes we've got at the minute already for this financial year. I'm sure it will continue to grow. So we've got more schemes, but we've actually got fewer individual QIAs overall. So we've got some central QIAs. These are for things like our procurement scheme. So our procurement colleagues do an absolute sterling job at procuring items cheaper or switching up suppliers. In doing that, they go through a whole raft of quality control. They pass, all of those items are kite marked. They're all trialed within theatres or in the wards or departments beforehand, and are signed off by clinicians. So almost why do that additional QIA? Same as our bioequivalence. Our drug and therapeutic committee review bioequivalents whenever there's some available, and we'll sign them off for patient use. We're just duplicating work. Variable pay, again, so bank, agency, overtime, those types of things. We've got just central QIAs for some of those schemes, and that's just to name a few. You know, taxes. We spend a lot on taxes at Leeds, and every CSU wants to reduce their taxi spend, but why do we need 15 or 20 different QIAs for each taxi scheme? We know that there's almost some standard work out there of what they should be following. So yeah, it's kind of it's a better process. There's those not applicable ones as well. So those are the ones that actually, yeah, nice guidelines says that we can change from A to B. We don't need a QIA. Let's just NA it. Let's not sort of waste operational staff time in, and almost it does stop that preventing people from doing the change. So some people didn't want to speak up almost before, didn't want to implement their 500 quid scheme because the paperwork took them ages. You know, they've never filled it in. The form itself is really straightforward. As you hover over the boxes, it's got little pop-ups to tell you a little bit of a paragraph to say exactly what we're looking for in those forms. So rather than a QIA and a nice set of sort of guidelines of how to fill it in as we had previously, almost the form itself is the form and the guidelines. You should just be able to pick it up and fill it in. And in terms of feedback, we've had some fantastic feedback. We've just started collecting all of our QIAs for the current year, and we're at 85%, and that's based on the 1180 something. It changes by the day, doesn't it, Jackie? The almost 1200 schemes that we've got in there, we've got 85% of the forms complete. The other 15% tend to be our newer stuff, so our stuff that's coming in, new schemes that have started over the last few weeks or the last month or so. Yeah, so there you go. And yes, happy to share the form.
And I think worth noting, we actually achieved 100%, didn't we, last year? By the time we closed it down, we had a QIA for everything that was still deemed that we needed it for, or an understanding of if we didn't need one, why we didn't need one. So did it fall into that bucket of it's a bioequivalent or it's a transactional thing that we don't need to do one for? So it's really helped us in terms of governance as well, and with our audits. And yes, we will absolutely share a copy of it. If would it be okay to send one on to you, Grace, and then you can share it along with the slides?
Yeah, that's absolutely fine.
Excellent. So we intentionally designed this to not take up your whole hour. So either you can take your time back, or if anyone's got any questions, we can stay on for a few minutes. Oh, got a hand up from Lucy.
Hi, yeah, thank you for that. I suppose a bit of a question is, I completely agree, obviously it's not always necessary, but if you had kind of your executive team have mentioned they want all your kind of SIP schemes to be CQIA'd, I suppose in a way, have you ever come across that before, and any support on really maybe allowing that, I suppose, risk thinking to reduce?
You know, we get told we're not risky enough. Our execs, I think, are pushing for us to, you know, even if you think it's really risky, bring it to the table, use that QIA as a tool to assess how risky that really is. And we have a process whereby if we answer yes to any of these questions, or yes, it could adversely impact patient safety, it will automatically take them to sort of a few different boxes to fill in where they can describe that, and to a risk matrix. And that gives them a score at the end of it. So if it scores less than 9, it goes to our patient safety and quality managers, and they will input into the mitigations that you might be able to put in place to overcome that and still be able to implement your change. If it goes beyond that, then it would go to our executives. So I suppose the bit that we haven't shown you in this is if this short form quality impact assessment comes back as there's no risk, we go ahead with it. But if it does come back that there might be there's a bit more to fill in and a bit more guidance. But I think we're lucky in that, again, like I said at the beginning, they've empowered us to say, this is your work. You know what will and will not work. You change what you think needs to happen, and we'll monitor the outputs of that. I think, and we did it in sort of a PDSA style for those of you that use that. We've monitored it as we've put it in. Jackie monitors every QIA after that to say, have there been any breaches? Has it had any adverse impacts? If it has, we stop it. I think if we'd found that we were having a lot more that we were needing to intervene and pull back and stop because actually we hadn't done a QIA, or we'd, for whatever reason, we would have pulled that and gone back to the old system. So we had a few fail safes in there.
Yeah, but nothing's happened, so far. We've been okay.
And we do have a quarterly sort of QIA audit, don't we? Where the senior team will pick a number of schemes and almost review those QIAs to make sure that that the forms are filled in correctly, and B, that we have a form and we have a process in place. So there is that additional check almost in there.
Yeah. So I think it's our chief nurse who's the senior responsible officer for QIAs, if anyone comes a knocking. So we have started to work a bit more closely with her, but I think real handy for us, she's taken the stance of use it as a tool. Tell us everything that you might possibly change that might give us a financial benefit, and we'll use the QIA tool to weed out the ones that will impact patients, and we put those aside. And essentially it makes it more transparent. Like, if our pharmacy colleagues say, actually, there's £2.8 million worth of money that we could have by swapping this drug to this drug, but then the QIA comes back, actually that's mega risky and we're not going to do that. It stops them then questioning, hang on a minute, you've got £2 million you could go save over there. So I think it's been a really useful exercise at making everything a bit more transparent as well.
Fab, thank you.
Elaine?
Hi, I'm also on the topic of central QIAs. I'm just mentally trying to work out when you choose to do a central QIA in the trust, who sort of like formulates the guidance or the template around that, so that if you say, all right, I've got a bioequivalent one that I want to do, what's the guidance say that I can use a bioequivalent one for, or what's the guidance say that I can use it for procurement? Because we're starting to do that in our trust. We are actually doing that kind of thing, but we're writing a QIA ourselves and sharing it with the other divisions, that kind of thing. And so we end up having one that's been written by one but covers everybody. And I'm just trying to work out how it works for you, really.
Yeah, so I guess for the procurement one, our director of procurement actually completed the QIA. For bioequivalents, we had our chief pharmacist fill in the QIA, and attached to that is almost our drug and therapeutic committee paperwork that was agreed that says that they will review all bioequivalents and will almost recommend those at a point. We wouldn't use anything that would be detrimental to a patient.
Yeah. Okay, thank you.
I think what's been really handy as well for me, we've not used it as it's not a hard and fast rule. So if our colleagues are still not quite happy with that, fill in your own QIA. So the bit that jumped into my head then was there was an opportunity to change the drugs for our HIV patients. So it was a bioequivalent. It was exactly the same drug that would do exactly the same stuff. So the Safety and Quality Medicines Committee, everybody had signed that off as in, physiologically it does all the same stuff. But the nurses that work in the HIV ward were really worried about, in terms of mental health for those patients, I don't know that we should be swapping the medication for some of these patients. So on top of the bioequivalence one that we had, we did a local QIA, and what that helped them discern was, or get to the point where they were like, actually 80% of our patients are, after review, mentally and physically okay to switch, but some of them are not. So for those small buckets of patients, we chose not to make that switch. So I think although we've still got the central ones, if we need to do another one at a local level for whatever reason, then they're absolutely empowered to do that and decide at that local level what they do and what they don't do.
That probably fits in my head, actually, because I was thinking to myself, well, I might decide I want to use the procurement one because we might choose to procure something different in our division. We might say that's what we want to do. But then how do I prove that I've taken it anywhere unless I've actually done a local one that shows an audit trail almost that we've actually done? We've looked at the main procurement list and we've said we meet the guidance, and we've got a record so it shows that we're following the guidance and we're not. So I do think we probably would do the local one so that we can show we've thought it through. Otherwise we don't have an audit trail, I suppose.
Yeah, and I think it was handy. It left them the space to do that local one and add value with that, because actually the bulk of it was covered in the main one. They just needed to think about those extra bits, like that nuance of what I know about my patient. So it didn't take them half as long to fill in, because they didn't have to go over all the, the drug changes and all the other stuff. It was purely just about their local intelligence. So it was really handy.
Yeah, lovely. Thank you.
Any other questions? I can't see hands up anymore. Everything's kind of disappeared. Is it Sani? Sani? I've butchered that. Sorry.
Yeah. No, that's fine. It's Sani. Thanks, Natasha and Thomas. I'm Sani Orgler. I'm the head of financial response recovery at Shrewsbury and Telford, and that was a great presentation. So thank you so much. I'm sure me and my team will take a lot away from that. I think my question is just around sort of the forum or the version that you use. Is that a software, that QIA? Is it just a Word document? Sorry if I've missed that, because I did join a little bit late. But is it an Excel sheet? I was trying to figure it out. Was it a Word, a software? And then how do you keep that centrally, and where do you keep it if it is as simple as an Excel sheet or a Word document?
Shall we hand over to Jackie? You can go through that. You store everything, and
so all the CSUs have got their own folders, and I put a QIA template and all the guidance in their folders, and they literally get it from there, and then all the QIAs are saved there. We did a bit of 5S on the QIAs as well, because we used to have different folders where it's a QIA that needed signing or a QIA that needed this, or we're waiting for information, and now we tend to have them all together, just so they've got the CSU name, they've got all the guidance and templates in, and then all the QIAs stored there.
We have a central drive set up where anyone within the trust should be able to access that within reason. I think some new starters get missed off, but anyone that's attached to the waste reduction programme has access to that drive, and each clinical service unit just has their own folder that they can nip in and out of. It is just a simple Excel spreadsheet.
It's just, it's just Excel,
Yeah, I'd love for it to be, to have some sort of flash and, software that did all sorts for us, but no money for that at the minute. So it is just a simple Excel spreadsheet. We did struggle a little bit with version control at the beginning, didn't we? Because, people have old ones saved on their desktop. So the next time they need to do one, the easiest thing to do is go back into that previous one and delete that off. And that was one of the defects that we found at first, wasn't it? So again, Jackie brought those back to the team and went, what do I do? Because it doesn't feel right to go back and say, sorry, wrong version, fill this new one in, and get them to rework it. So we had a bit of a discussion in our 5S team and said, right, Jackie, you just transfer all that information over, but they absolutely need to know there's a new one. So once you've filled it in, send them the new version back, just so that they're aware, and then the next time they'll use the newer version. So we had a few come through on old ones. for a while, but we've sort of weeded those out and just made sure that everywhere that we have this, so we've got one on the intranet, we've got one in that drive, anywhere that we have anything, we've gone through and removed as many old ones as we possibly can.
That's great, thank you.
Yeah, I think it just depends if, like you say, they do keep them on the desktop, and if they go to that rather than going to where they should go to, that's when there's a problem. But we've been pretty lucky with it, I think. We've not had no major problems at all, have we? It's just little tweaks, little things.
Yeah.
Great, thank you.
Any more? Possibly not. No. But well, thank you everybody for coming and listening to us. We will share the slides, we'll share our QIA, anything else that you might want. I think our email addresses usually get shared as well. So you can drop us an email, give us a shout on Teams if you've got any questions. We'd be happy to help.
Yeah, we will. Yeah.
Thank you very much. That was really helpful.
Thanks, everyone.
Okay. Bye-bye.
Thank
Thank
you.
you.
Thank you.
Thanks very much.
Bye.
Thank you.
Bye.